Okay, so we're going to be talking about the respiratory system next. And basically, as we're going through this, we want to talk about all these kind of areas here, how it's organized, how it works, physiology, the control of respiration. Again, this is going to be a very brief overview. I'm expecting you know some anatomy, physiology, and this is a review. But we're going to get more detailed in our first module with this respiratory aspect. So if I go too fast in this section or anything like that, again, this is, remember, just a review. We will be going more in depth in this aspect. So our biggest thing we're doing is we're getting gas exchange. That's the main function of the respiratory function of the respiratory system. It's getting oxygen exchange for CO2, and that's our form of exchange. And that's going to be able to tell us a lot of things as we get into acid base and other aspects as well. Not only that, but this basically allows us for talk, smell, lots of different functions. Dehydration, it can help cool us off when we're hot, lots of different things on there. So how is the system organized? Well, basically the whole respiratory system is designed with the mouth and nose to start off. It's a tubular based system. Obviously this is part of the digestive system as well. Going to come down and then we'll get into the trachea through the vocal cords, down through the bronchi, where we hit and tube off into our right and left lungs. Once in the lungs, this is going to go down even smaller from bronchioles to an area where we get into these alveoli, or these grape-like sacs, which have got this massive capillary network around it, and that's where gas exchange occurs, oxygen for CO2. So that's really our setup in here. So we basically have the respiratory tract divided up. Again, we've got the nasopharyngeal passageway. So we'll talk about that later in, of when do we use a nasopharyngeal. Talk about intubating through the nasal area besides just normal oral intubation. And then talking about all that tract all the way down. So basically from the nose and the oropharynx area, this is going to filter, warm. We've got lots of hairs and other aspects in the nasal pharyngeal passageway to catch debris. And then basically it helps to warm and build that area up. And then we get all the way down to the smallest of bronchioles. Here's a close-up kind of just looking from here. We've got the nasal concha, the vestibule up in this area. Our hard palate, again, when we're kids, we don't have this. This is a soft palate, so we have to be careful how we can insert OPAs. But otherwise, we have this hard palate we can rotate our OPAs on. The tongue, again, in kids, our tongue is going to be a huge aspect of here. In adults, it's still a big aspect, but it's not as big. And we've got to see about holding this area up, and that's why the OPA is, so it doesn't fall back and plug up this oropharynx. Our other components, we have our epiglottis. We have the vallecula, which we'll talk about as a component. This is where if we're using a Mac blade for intubation, that's going to go right here into the vallecula, where a Miller blade is going to go over top of the epiglottis to help open and give us exposure. The laryngeal pharynx, or basically the area from the larynx down to the pharynx, opening. Our glottis, which is our actual opening there. And then we have our vocal cords in between here. Front kind of protection, we have our thyroid cartilage and our cricocartilage, and then down into our trachea, and our esophagus being basically behind that. So that's really our setup on here, and that's what these videos or these pictures are going to continue to do. So we have a respiratory mucosa, which is basically this protective membrane, goes the nasal cavity, and that epithelial I talked about, basically up in this area that basically catches debris and anything else floating in there, smoke and that, to try and keep that as a filter system out of our respiratory system. And then the three main divisions, we have the nasopharynx, the oropharynx, and then the laryngeopharynx. So we're basically talking nasopharynx, oropharynx, laryngeopharynx as those divisions, oral, nasal. And that's about the most extent I'm going to get of those right now. Now, as far as the larynx is concerned, when we're looking for our landmarks, our big one is our thyroid cartilage that we're going to find, and it's right here. There is some cartilage that comes up in, it's more of a fibrous than a hard cartilage that comes up to the hyoid bone as well. but this is our thyroid cartilage and this is our cricocartilage. These are our two main landmarks that we're looking for. What we're looking for is if we need to do a surgical airway or a needle jet airway anyway, this is the area we're needing to go. So we need to know those two landmarks so we know exactly where we're going to be cutting to get in to that spot. So those are the important aspects. When we look on the back side of this area and we're looking to the spot so we can come and we'll be actually below the vocal cord so we're not interrupting the vocal cords. That's a big part. And that's what this thyroid cartilage is protecting immediately behind it. So this gets us in the right spot in this area down here below the vocal cords to get in. Our epiglottis is going to be basically a fold that comes over and it protects it. So as we swallow, it closes down over to try and prevent any items from getting down into the trachea. And here's that close-up look once we look into the larynx, which is our entrance down into the trachea. We'll see the epiglottis, which is this fold, looks like a tongue, and this will just drop down over top. Here's our vocal cords, which are normally nice, pearly white. And then we have this ligaments over here we call the false vocal cords, which will open and close to allow vibrations across, and that's where we get our speech and sound and everything else. And here's another close look of it. So the vocal cords here closed at this point in time, but kind of a pearly white appearance, and that's what we're looking for. And here's another close-up of this. All right, and then our coughing reflex I'm not too worried about. We're going to talk about there. Here is now, when we talk about the trachea, and it comes down, we have those cartilaginous rings that come down and support that. Basically, this is going to hold it open, so pressure around here doesn't close that off. So that's why we have that here. As that comes down, it splits off into our primary bronchi. You can see that the right side comes down really easy. That's kind of the natural flow, and the left side kind of shoots off. This looks like it is equal here, but in reality, the right side is the more normal flow. And so this would be important when we're checking lung sounds after intubation, where we see right-sided but not left-sided, is we usually get that right main stem. So the tube could actually inserted too far in place down in this area, and we're not getting respirations on the left, and that's usually where we'll back it up. But this is the natural flow is into the right, not necessarily into the left. Once down in here, these will break up into secondary bronchi and go into bronchioles, and then down in the very bronchioles, it'll end up into these alveoli sacs, which are basically these grape-filled clusters filled with surfactant to keep them open. And then the blood vessels come all around here, and that's where our gas exchange occurs. So when we're in respiratory distress, it can happen from a lot of different things that can go up there, a lot of different characteristics. So one of the big things we look at, especially when we're dealing with infants, especially premature, is this surfactant. Inadequate surfactant is this liquid, basically it's a high viscosity that basically keeps those areas open. It's produced at a certain age. We'll go back when we're talking about infants. But anyways, when we get preemies that don't have enough surfactant, it's hard to keep those alveoli open. Also, when we're dealing with fluid into the lung, other things that can wash away that surfactant, infection like pneumonias can intersect with this. So a lot of different things that can come up. So that's one of the big things we look at any time of respiratory distress. Other things here, and when we get into respiratory, I'll go more in detail about those. Today, again, I just want to talk about the basic aspects and go over. Pulmonary embolism we'll talk about later, how to identify that on a 12 lead, also based on history and exactly where it can block up and how an emergency is going to present. When we look at the lungs, basically, here I want you to know that the right lung has 3 lobes, the left lung has 2. Here shows more of that right side coming down at more of an angle, and that left side shooting off a little bit more. So the right side is the normal flow. Left does shoot off. It's not quite a 90 degree, but it's more so than this. Easy way to remember this is on the right side, we have 3 items. On the left side, we have 3 items. The right side is the 3 lobes. The left side is 2 lobes and the heart. It's centrally to left side placement. But those are an easy way to remember that as well. I'm not going to go over except for more saying this is the apices, this is the bases. So we're listening to apices and bases when we're looking at lung sounds. And that's going to kind of tell us how they are. And these lungs sit into a pleural cavity, is its area here, and they have a pleural lining that surrounds that. This is also going to be areas when we're talking about difficulty breathing or chest pain is, are we having pleuritis or an infection of the pleural lining, or are we truly having chest pain, or are we having lung issues, things like that. So again, the anatomy is where I'm looking at position-wise. You can see the heart is centrally placed in this photo, but technically it is a little bit off to the left side, more so than to the right. It's more centrally and left, so just another way to kind of go through that. We can have a lot of injuries to that area, to the chest wall, can cause bleeding. Bleeding into that pleural cavity is what's called a hemothorax. That area can fill up with blood, gives us some dull sounds. When it fills up with air, it can be a pneumothorax. Talking into the physiology, again, our main portion is ventilation, getting oxygen in and out, then having gas exchange, and then transporting that gas exchange, that oxygen to the heart and the CO2 to the lungs. So breathing is our normal motion. We need to know what our normal breathing is, and then we get that diffusion or gas exchange outside the mouth, brought inside. Oxygen comes down into the lungs, goes down into those capillary beds, and it has a high affinity for attaching to hemoglobin. CO2 is released, and then we breathe CO2 out. Problems we can get from this is hypoxia. Basically, we're getting low oxygen concentrations, or anoxia. Basically, we're not breathing at all or getting any oxygen flow. Those can happen with choking and other aspects too. So we want to make sure we're in that normal respiratory cycle, normal breathing rate, and again, that varies per age. So we'll be talking normals a lot in here. And then the alveoli is at our exchange. Our diaphragm is our main muscle that sits below the lungs, and basically will contract and expand to cause the lungs to be able to squeeze out and squeeze in. It's a dome shape, kind of fits right over top of the liver and the stomach, and then right below the heart and the lungs, and kind of helps to push with those areas too. So when it contracts, it flattens. When it relaxes, it basically builds up. And this is all protected by the rib cage, but again, a deep contraction, it can actually extend down below the rib cage, and you can actually have part of your lung can be actually unprotected by the rib cage on an extreme inhalation. So being aware of that area. Again, here's our rib cage right here. Our lungs are inside that, but it can expand down below at times, same as it can come back up. And here's our diaphragm, that dome shape right here. And this is going to talk about the inhalation process of basically increasing the pressure gradient and decreasing it. And we'll talk about how this relates to our Spokane County protocols with CPR down the road as well too. I'm not going to get too much into these areas because we're going to get them into later. I do want you to know lung volume. So there's tidal volume. This is the air that's moved in and out of the lungs in a single respiratory cycle. It's about 500 milliliters or 500 cc's. Milliliters, cc's, same things. And then only a small amount is exchanged. So this is with a normal respiratory breath. If we take a deeper breath, we're getting more oxygen in. If we take a shallow breath, we're getting less of exchange. So rapid shallow breaths are ineffective breaths, and we're not getting good gas exchange. Deep breaths, we're getting more than normal, and just a normal volume we need to know. So, and then our expiratory reserve volume. This means when we blow out air, we usually have to have so much air that basically stays within the lungs and holds the lungs open. And our inspiratory reserve volume is basically when we inhale, there's so much that's held up inside, what's also called a dead space. Those are the big things that I want you to be aware of those aspects and understanding that you have to have that. Then as far as we're dealing with gas exchange, again, once we get into this alveoli over here, and the blood is coming by, we're getting deoxygenated blood coming through, has a high affinity of binding for oxygen, so it comes across this gradient. Again, we get diffusion. We have a high concentration of oxygen in the alveoli, a low concentration in the pulmonary artery, so oxygen wants to go across and it wants to balance those out. Same with CO2. We have a low concentration of CO2, a high concentration of CO2 in the pulmonary artery, and it diffuses across to a pressure gradient this way. And that's where we get exchange. Then that flows through the pulmonary vein, and then that will come back down to the heart, and that's our process.